So let's look at the concept of brain herniation, which is extremely serious and often can result in death. Brain herniation. So the word herniation typically means that tissue in one compartment is squeezing through into a compartment where it doesn't belong. So when we're talking about herniation of the brain, there's a very strong ligament between the cerebral cortex on both sides and the cerebellum below, cerebellum and brainstem. And as pressure builds in one of the cerebral cortexes, or intracranial pressure in general, it's going to force some of the cerebral cortex to herniate downwards towards the brainstem and the cerebellum, and that's called brain herniation or temporal lobe herniation, because that's the lobe of the brain that typically squeezes through there, and that's very serious because you're now compressing the brainstem, which is responsible for most of your autonomic functions. And this is where Cushing's triad comes in, where the brainstem's being compressed. So they're now hypertensive. They're in a coma for sure. They have bradycardia. They have abnormal temperature responses. And their respirations start to slow down. So because the brainstem is responsible for all those functions. Okay. The other thing that'll happen is on the same side of the herniation, the pupil will dilate. So pupillary dilation is cranial nerve number 3, and it's part of the brainstem. So as it's being compressed on that side, it stops functioning, and the pupil on that side dilates. So if we see a fixed dilated pupil with someone who's unconscious, and a fixed dilated pupil on one side with someone who's unconscious, we immediately will think of brain herniation. And the herniation, as I said, is typically a part of the temporal lobe. And the name of the temporal lobe, of this little part of the temporal lobe that herniates, is called the uncus, U-N-C-U-S. So we call it uncal herniation. Okay? So that's the concept of brain herniation below the tentorium cerebelli that separates the cerebral cortex from the brainstem, and a piece of the temporal lobe squeezes through and results in compressing the brainstem downwards, which is usually a critical event. Okay, so let's go through the concept of brain herniation. So again, it makes complete sense. So the upper brain structures, which are above that tentorial ligament, so that would be your cerebral hemispheres, are separated from the lower brain structures like the cerebellum and the brainstem. And this is from that very strong ligament that supports the cerebral hemispheres above it. And as the intracranial pressure increases, that will lead to a herniation, typically of the temporal lobe of the brain, through the tentorium and into the lower area, the infratentorial section, where the brainstem and cerebellum are. This is really not a good thing. So first of all, there's a lot of intracranial pressure that is occurring to do this. But the other issue is that this tissue that's herniating is now compressing the brainstem even further. Okay, so all the brainstem functions are going to function abnormally, and typically that's heartbeat, respirations, blood pressure. Remember Cushing's triad: hypertension, bradycardia, and bradypnea, or slow breathing. that will happen as the brainstem is compressed. So it's really a end of the line um, uh, uh, problem. This is critical. So as this temporal lobe herniates, which we call uncal herniation, below the tentorium, it also compresses the third nerve, and the third nerve is responsible for pupillary constriction. So when you compress the third nerve, which is in the brainstem, it leads to unilateral fixed dilated pupil on that side, a blown pupil. That's why if someone's unconscious and we see a dilated pupil on one side, that is an indication of increased intracerebral pressure or intracranial pressure and herniation, uncal herniation on the same side. Okay. So as this herniation progresses, you're definitely in a coma. You're going to have abnormal posturing, which we're coming to. I know we've said it many times, but we are coming to it. And then finally, death from lack of any brainstem function. So really, when we see a blown pupil in the setting of a trauma with someone who's unconscious, we're going to get out mannitol or 3% normal saline to try and pull some of the fluid away from the brain, and as well obviously involve a neurosurgeon to see if there's anything they can do to reduce the intracranial pressure that might help the herniation to resolve. But usually this is a critical condition, and people often die of brain herniation. So let's look at different pupillary responses. So starting at the top, when we shine light into pupils, into your eyes, we expect both sides to constrict equally. And that's what we're seeing at the top one. The second one down is showing that on the right side, the pupil constricts briskly, which is normal, and the left side is constricting sluggishly, slowly, okay? And that can be an indication that something is happening on that side of the brain. The next one, the third one down, there's a dilated pupil, even though we're shining light into the pupils. And this is often an indication of brainstem herniation on the same side as the dilated pupil, because cranial nerve 3 is being compressed. The next one is fixed dilated pupils on both sides. So in order to do that, you have to have extremely high intracranial pressures that's putting pressure and damaging both cranial nerve 3s on each side. So this is basically a pre-death or just at death scenario, fixed dilated pupils. So when we look at someone who's unconscious and they have fixed dilated pupils, that's massive head injury, and it's a terminal event usually. And lastly, the pinpoint pupils. And there's two conditions that give you pinpoint pupils. One of them is a brainstem stroke, typically in a part of the brain called the pons. And damage at the pons gives you these really pinpoint pupils. Okay. The other condition that does this is narcotics, opioids. Okay, so when we look at if someone comes in and they've had an opioid overdose, or we suspect they have, and they're breathing slowly, they're unconscious, we look at the pupils and they're pinpoint. That is an indication that they have overdosed on narcotics. So here's the slide of different postures. And these are very abnormal postures in severe brain damage. And one of them is called decorticate, and that'll be the bottom one, where um, you have flexing of the arms, adduction. So adduction means that the arms are right against the chest, and the elbows are flexed. The arms and fingers are flexed inwards. The legs are fully extended and they're turned inwards a bit. And the feet are completely plantar flexed. So that's decorticate. And that's an indication of severe brain damage. Even more concerning, this is already an extremely concerning posture. Even more concerning would be decerebrate posturing, because that usually means that the brainstem is now involved. And you can see the difference here. So the arms are still adducted, they're against the chest wall, but now they're extended, the elbows are extended, the wrists are turned inwards, and the fingers are still flexed. And the legs are still fully extended with plantar flexion of the feet. So you can have a whole mixture of these. One side can be decorticate and the other side can be decerebrate. Or you can have decorticate on both sides. There's a whole mixture of what you can have. It doesn't have to be exactly one of these. You could have just decorticate posturing on one side and nothing on the other, or decerebrate posturing on one side and nothing on the other. There's all kinds of mixtures that you can have from these posturings, and both of them indicate severe brain damage, but definitely decerebrate is an even more advanced brain damage. Okay, so let's do this question together. So what treatment should the nurse anticipate for a patient with an increased intracranial pressure? So this will probably take you back to the electrolyte and fluid module, and remembering what do we want to do with someone who has increased intracranial pressure. Remember, the skull has a fixed volume within it. Okay, the skull cannot expand in an adult. It can expand a bit in a child, but definitely not in an adult. It has a fixed volume inside. So what we want to do is we want to pull out some fluids to try and reduce intracranial pressure. That's the key. So let's look at the first answer, hypotonic solutions. So solutions that have lower concentrations than what's in the bloodstream and what's in the extracellular space. Well, that's going to cause fluid to go from the intravascular space and go into the brain even more. We don't want that one. What about isotonic saline or isotonic solutions? Well, they won't do very much, right? In actual fact, they may cause some harm because we're just giving more fluids to someone. And some of that fluid is going to go from the vascular space and it's going to go across the blood vessels into the extracellular space. So, the interstitial space. So that's not going to be helpful either. What about hyperventilation? So hyperventilation causes your pCO2 to go down. So when we breathe fast, we blow off CO2. And by blowing off CO2, the cerebral blood vessels, the cerebral arteries, vasoconstrict. Okay? So by hyperventilating, we're vasoconstricting the cerebral arteries. And that's going to reduce the overall volume or space that the blood vessels are taking within the brain. So we would hyperventilate someone. Okay? So we have to be a bit careful with hyperventilation, because if we over hyperventilate someone too much, we're causing so much vasoconstriction that can reduce the blood supply to the brain. Okay, but in general, we use hyperventilation in emergency situations, such as increased intracranial pressure, to cause cerebral vasoconstriction and reduce the overall volume that the blood vessels are taking up within the brain. Okay, so that would be the answer. Hypoventilation would cause an increase in CO2 in the bloodstream, resulting in vasodilation of the cerebral arteries. We definitely wouldn't want that one. So the answer is C. We would also, by the way, give 3% normal saline, which is hypertonic, to try and draw out some of the fluid that's within the brain and pull it into the vascular space so that it can be taken away. And that will reduce some volume as well. So we could use 3% normal saline, or a large molecule such as mannitol can also be used for the same purpose. Okay, so let's do another question together. Place the following events or complications in order which occur with brain herniation. Okay, so brain herniation means that there's so much pressure within the brain, and it has really nowhere to expand to. It can't expand the skull, so it's going to expand downwards, okay, towards the spinal cord. Okay, so what's the first event that happens? Well, you have to have increased intracranial pressure, high ICP, from whatever cause. So whether it's from a hemorrhage in the brain, or it's from a significant head injury causing cerebral edema, whatever the cause is, the first event that's going to lead to complications is high ICP. Okay, so as the pressure builds and builds and builds in the brain, it has to move somewhere, right? And it moves downwards, and it leads to uncal herniation. So there's two parts of you can think of the brain as kind of split into the upper part, the supratentorium, and the tentorium is a very, very strong ligament, a membrane that separates basically the cortex, the two cortices, and the lower part of the brain, the brainstem. And as the pressure builds and builds within the upper part, or the upper chamber called supratentorium, it pushes downwards, and part of it herniates. And it's pushing so hard because of the pressure. The portion of the brain that herniates is called the uncus, so it's called uncal herniation. And it just so happens that the third nerve, the third cranial nerve, is right there. So after uncal herniation, the third nerve can't function properly because it's being compressed. And the third nerve controls pupillary size, right? So when the third nerve is injured and compressed, the eye dilates on the same side as the uncal herniation. So you get what's called a blown pupil, a dilated pupil. Okay? And as the herniation continues, and now the brainstem is being compressed and squashed, you start to get posturing, right? The decerebrate and decorticate posturing. And finally, as the brainstem is compressed even further, now your respiratory and cardiac centers aren't functioning, and that leads to death. Okay, so we're going to go on to a new topic, neural tube defects. So the neural tube is basically the brain and the spinal column and the spinal cord that develops early on in the fetus. And the spinal column usually completely closes with vertebra to protect the spinal cord. And when it doesn't completely close is where we can get into conditions called spina bifida, okay, which is an opening in the lining of the spinal canal. And we'll look at photos of this. And it used to be much more common. It still happens, but we've discovered that if expecting mothers or people that are trying to get pregnant are on folate supplements, maternal vitamins that have folate in them, it's much less likely for them to develop, or for the fetus to develop spina bifida. So we discovered this link that, folate deficiency can lead to spina bifida. And the nervous system begins developing extremely early on, like at 3 weeks, it starts to develop. So it's really good to have folate on board before getting pregnant because the spinal column develops so early. So we'll look at the there's different degrees of spina bifida. The signs and symptoms. So it's protrusion of the lining, the meninges. Those are the layers of the brain, of the spinal cord, which will still be the layers that go up into the brain as well. Okay, and it's dependent on how much is bulging out. Okay, so if there's no protrusion at all, and it's just a defect in the bony vertebral column, then we call it spina bifida occulta. Okay, and often there's a dimple there or a tuft of hair or some kind of marking there where you can tell that the vertebra just didn't totally close, but the skin is intact and there's just a tuft of hair or a dimple there. And we often look for that after a baby is born. The next one is called a meningocele, where the layers of the spinal cord are bulging out, are herniating out, but there's no neural tissue, there's no spinal cord tissue within it. And then the next one is myelomeningocele, which is the most significant one, where there's nerves and the layers, the meninges, that are sticking out into the neural tube defect. So spina bifida is a spectrum. We tend to do maternal blood screening when women are 16 to 18 weeks, which can help us pick up abnormal neural tube development, and one of them being spina bifida. And we can do focused ultrasounds if that's positive to see if there is a significant neural tube defect at that location. So fetal ultrasounds are done. We typically do a fetal ultrasound anyways at around 18 weeks for dating of a fetus. Amniocentesis would not usually be something that we typically do. The maternal blood screening is offered to everyone. The fetal ultrasound is done, as I said, typically at 18 weeks. So often on ultrasound and with the maternal blood screening, these can be picked up. The treatment is usually surgical closure to prevent further damage to the spinal cord. But it doesn't reverse any damage that's already happened if there's a whole bundle of nerves that have been sticking out in a meningomyelocele. So we'll go to the diagram on the next page. So here's the spectrum of disease for spina bifida. You can be just missing the spinous process at the back, where the vertebral column hasn't fully closed, and you may have a little dimple there or a hairy patch, but nothing is protruding. So the meninges or the nerves, the spinal cord, aren't protruding out. Okay, so that's by far the least serious. The next one is called a meningocele, and that is where the meninges, the layers around the spinal cord, are herniating or protruding out, but the nerves haven't been taken with that herniation. And the next one is a myelomeningocele, and that's protrusion of not only the layers surrounding the spinal cord, but also the nerves themselves. And this is the most serious because the nerves have been damaged by this herniation and maldevelopment in the fetus, in the fetal stage. So they're often left with potential paralysis of the legs. They're often unable to urinate. They're incontinent. They often need catheterization, of the bladder. So they run into a lot of urinary problems and leg weakness and potential paralysis.